we're talking about valvular stenosis. I'll do the first 30 minutes, and Dr. NABI is going to do the last 30 minutes talking about the role of MRI in valvular stenosis. So the role of echo in aortic stenosis is to evaluate that patient with the classic murmur, aortic stenosis murmur, who may or may not have symptoms. The echo images, the 2D images, allow you to determine the etiology of the aortic valve stenosis, whether or not there's any upstream effects such as left ventricular hypertrophy. It also allows you to evaluate the LV and RV function. The Doppler allows you to determine the gradient across that stenotic valve, determine the aortic valve area, and downstream effects, specifically pulmonary hypertension. So here is a classic case of the most common form of aortic stenosis. And this is calcific or degenerative aortic stenosis. And basically, you can see from both of these images that the aortic valve is very calcified, and it is involving mostly the leaflets. So it's starting at the leaflet tips and going all the way down to the leaflet bases. Let's give you another example. So this, compare and contrast this to rheumatic aortic stenosis. Here you can see all the calcifications along the commissures. So the leaflets are pretty well spared. So it starts at the commissures, and the commissures are very calcified and thickened, and you can see between that right and non-coronary cusp that it's completely fused. Of course, we see bicuspid aortic stenosis. The best way to determine whether or not it's a bicuspid valve is in diastole, because frequently that median raphe can make you think that there's two rather than one leaflet in systole. So you're literally looking in diastole, it should open like that football shape, and you're counting the leaflets, so you clearly see two. The leaflets are frequently unequal in size, so when you look at the long axis, what you'll see is not only that doming when they open in diastole, but when they close, you can see this asymmetric closure, because frequently one of the leaflets is larger than the other. So this is a patient of mine. She had a subaortic stenosis muscular ridge, which is another form of aortic stenosis. And you can see there's a big chunk of muscle sitting right there in the left ventricular outflow tract. And you can see that the mitral leaflets are absolutely normal. So the mitral valve is not playing any sort of role in this obstruction. And you can see when you look at the color in the bottom left-hand panel that there's flow acceleration right where that big chunk of muscle is. And when you put the continuous wave Doppler on there in the bottom right-hand panel, what you see is the aortic stenosis severity isn't that huge. It's not like valvular stenosis. The curve looks like valvular stenosis, but it's just not that large. And you can see that there's some AI. And frequently in this disease, that high pressure gradient keeps pounding on that aortic valve. It degenerates, and it leads to more and more AI. So compare that to the other form of subaortic stenosis, and this is dynamic subaortic stenosis, or hypertrophic obstructive cardiomyopathy. Looks very, very different. Here you're seeing the severe asymmetric LV hypertrophy. You're seeing that systolic anterior motion of that mitral leaflet, which is causing some of that obstruction along with that hypertrophy. Because of that mitral leaflet involvement, you're seeing that very asymmetric mitral regurgitant jet. It's always directed posterior laterally. And then finally, when you look at the continuous wave in the bottom right-hand panel, the jet looks very different. You can see that the peak velocity of that stenotic jet is occurring in mid to late systole, so it has that very characteristic, what we call a blade shape. This is a very rare cause of aortic stenosis. This is a quadricuspid aortic stenosis. You can see all four cusps there on the very first upper left-hand panel on TEE. You can see in the long axis, you can see that there's, again, you're seeing three of the leaflets there with two commissures. You can see that there's severe left ventricular hypertrophy. On TEE, of course, it's very difficult to get aligned or parallel with that stenotic jet. So you can see that it's at least, on that bottom right-hand panel, at least that peak velocity is more than 4. So there's severe aortic stenosis, but we just can't on TE get aligned, so we can't tell you exactly what it was. So how do we calculate the pressure gradients across stenotic valves? Well, we use the Bernoulli equation, and the whole Bernoulli equation is listed on the top, and it's just showing you how you convert pressures to velocities. The two terms we completely get rid of because they approach 0, because there's very short acceleration and brief contact with the walls of that valve in the left ventricular outflow tract. And when you look at the two velocities, velocity 2 is that stenotic jet velocity. Velocity 1 is that pulse wave. So you can see that that stenotic jet is way much smaller, or much higher than that pulse wave jet. So you can get rid of that V1, and we end up with that change in pressure across that stenotic valve being equal to 4V squared once we modify all those and drop out all the things that approach 0. When we look at Doppler versus catheter-derived gradients, these are showing you the two pressure gradients, and the mean gradient is depicted there in the cath lab, what you're measuring, and also in the echo lab, you're just measuring all those modified Bernoulli 4V squareds in that shaded area and taking the mean of the number of measurements that are made. You can see that the peak-to-peak gradient, because it occurs at 2 different time periods, it's much smaller than that peak instantaneous maximal gradient that's shown in the left-hand panel. So there's a big difference in those two, and actually that peak-to-peak more closely approximates the mean gradient than it does that peak instantaneous or maximal gradient. So there are pitfalls to only measuring the pressure gradient when trying to determine the severity of aortic stenosis. High flow rates are going to lead to high transaortic pressure gradients with only a moderate degree of valve narrowing, and this occurs with anemia, aortic insufficiency, thyrotoxicosis, anything that leads that LV to be hyperdynamic and leads to high flow rates. Low flow rates, the converse is true, is going to lead to very low transaortic pressure gradients despite severe aortic valve stenosis, and that happens with your cardiomyopathies and severe LV dysfunction, also with severe mitral regurgitation. So then we need to rely on something more than the pressure gradient. So of course we need that aortic valve area assessment. So how do we calculate the aortic valve area? Well, this is just showing the continuity equation where we first need to determine that cross-sectional area in the left ventricular outflow tract, which is where we're going to measure the flow. And once we have that area, which is just the diameter squared times 0.785, if we multiply it by that pulse wave time velocity integral at the same point that we measured that cross-sectional area, we can get a pretty accurate stroke volume. Once we have the stroke volume, if we divide it by that time velocity integral across that stenotic aortic valve, so that time velocity integral of that CW jet, we can calculate that aortic valve area, and this is just showing an example of calculating that. Now, there are a lot of technical considerations when using the continuity equation and measuring aortic stenosis. And probably the most important one is measuring that left ventricular outflow tract correctly, because this value is squared, which we just saw previously, that cross-sectional area is squared. And you have to, sometimes it's difficult because there's so much calcification of that aortic valve and so much blooming artifact from that calcium. But you can see in the first example, it's not completely aligned with the leaflet tips. So again, it's going to probably overestimate that left ventricular outflow tract. In the second upper right-hand panel, you can see that it's going down to that non-coronary cusp, so it's not really measuring the left ventricular outflow tract. The same as in the third, they're inside the leaflets. And so you really want to get in front of the attachment of both of those leaflets to get the correct measurement, make sure that you're not angling it. Now, how can you, another very important thing is to make sure that you're measuring the pulse wave Doppler at the same place that you just measured that cross-sectional area of the left ventricular outflow tract, so that you get an accurate stroke volume. And how can you do that? Well, you start off in the apical 5 or the apical 3 or the apical long view, and basically you stick you stick your sample volume, your pulse wave sample volume right in there, and you slowly advance it until you have both an opening click and a closure click, and then you back it off so you just have a closure click. So that tells you that you are at, once you just have that nice smooth contour with just a closure click, that you are at that same value that you measured that left ventricular outflow tract and determine that cross-sectional area. Now, another problem with aortic stenosis that we see quite frequently in the lab is you have to record that peak velocity of that continuous wave jet, of that stenotic jet. And in order to get that correct peak velocity, you have to be parallel with that stenotic jet. And this requires multiple sampling locations to permit that ultrasound beam to be aligned with that stenotic jet. And frequently it's not just with the guided CW images. frequently it's with that blind CW probe, because that blind CW probe has excellent maneuverability and it allows you to move it so that you can get better aligned with that stenotic jet. Because if you're not parallel with that jet, you're not going to get the peak velocity and you're going to underestimate the severity of the aortic stenosis. So this is showing you that basically some continuous wave Doppler of in the same patient from different locations using that blind PEDOF probe. And basically you can see that the peak velocities are all over the place. The first one is just not a very good jet, but it's from the apical location. The second one is an apical. The third one is a suprasternal notch, and you can see the velocity is barely above 1. And the last is a right parasternal. So you can see that if you wouldn't have taken the time to try all the different positions, you may not have gotten the peak velocity in this particular case. If you can't, after using that blind PEDOF probe and you looked at it and on 2D it looked like it was severe, you can use ultrasound contrast to try and get that peak velocity. It will overestimate it by about 15%, but at least it'll put you in that correct range of mild, moderate, or severe aortic stenosis. And I don't know why it's not playing. Let's try it again. So it was playing earlier. Oh, did you see it up there? Oh, so I can't see it. Okay, thank you. So you can see in the very beginning that there's absolutely no signal whatsoever. And as the contrast comes in, there's a perfect contour, and you can clearly see the peak velocity. So that is something that you can use if you've tried and tried and tried with guided, blind, you just can't get it, please use contrast, because it does work in those very, very difficult cases to put you in the right ballpark for the stenosis severity. Now, as aortic stenosis progresses, basically the systolic ejection period prolongs, and the time to that peak, there's a delay to that peak stenotic jet, which is that pulsus parvis et tardus that you feel on exam when you're palpating somebody's carotids and listening to their murmur. And it can become very difficult looking at those blind PEDOF signals to try and determine which one, especially if the patient has multiple valvular lesions, which one is actually the stenotic aortic jet. So what you can do in this case, there's two tricks. You can look at what's happening in diastole, and you can also look at the systolic ejection period to try and figure out whether or not it's holosystolic or whether or not it's just occurring during the systolic ejection time. And sometimes you can literally just measure it with the guided and then take it to your blind, and that systolic ejection time should line up, and that'll help you determine exactly which jet it is, which one is the correct jet. So in this particular case, the one on the left is actually a severe tricuspid regurgitation jet. So that one doesn't last throughout systole either, because you have early equalization of those pressures. The one in the upper right-hand panel is aortic stenosis, and you can see that it is occurring just during that systolic ejection time period and not throughout, just based on that QRS, not throughout systole. The one on the bottom left is a tricuspid regurgitation jet, and you can see that's occurring holosystolic throughout systole, and the one on the bottom right is mitral regurgitation. Same thing as tricuspid, it's holosystolic. Now, the role of TE in aortic stenosis, well, you can try and planimeter the valve if you want. There really isn't any role for TE in aortic stenosis, but you can, if you're doing it for other indications, you can go ahead and planimeter it. You just have to be careful that you're at the tightest, most stenotic part of that valve, which is always the tips, because this is showing you the same patient. One is more towards the annulus, and the valve area is 1.32. The next one's towards the tip, the most stenotic part, and the planimetered valve area is 0.55 centimeters squared. So how do you know you're at the right location? Well, you start off at 120, where you see both of the leaflets equally. In the left ventricular outflow tract, you see them both equally, and then you don't change your level. You don't push the probe in, you don't pull the probe out, you just leave it right at that level, and then you zoom it, freeze it, and trace it. And that will get you the most accurate planimetered value. So determining the severity of aortic stenosis in AFib is difficult. And there's two things that you can do. And it's just difficult if the RR interval is varying, as in this particular case. So you can either average 5 beats to try, and it'll get you in the ballpark. It's not going to be an exact number, but at least it'll tell you whether or not it's mild, moderate, or severe. Or you can take the most representative RR interval. So that's the one that occurs the majority of the time, and you can measure that RR interval on pulse wave, and you can measure that RR interval on CW, and you can match them. And as long as you've got the same RR interval and it looks like it's the one that's happening the majority of the time, it should again get you in that ballpark of severity of aortic stenosis. So this is just based on AHA, ACC guidelines and ESC guidelines for aortic stenosis severity. You can see that they're a little bit different, but they're generally in the same ballpark. And I think the one that I find the most useful is that velocity ratio. It really helps you when everything is all discrepant and you're trying to figure out, well, is this severe or is this moderate? That velocity ratio really helps you in determining whether or not it's severe. So aortic stenosis is an integration of findings, especially in somebody with low flow, low gradient aortic stenosis, because they can have symptoms just due to their cardiomyopathy and their heart failure and not necessarily due to their valve. So the symptoms aren't going to really help you. So you're going to need something else to try and tell you, is this severe or pseudo-severe aortic stenosis? And that something else is dopamine Doppler. And basically, you're looking for two things. You're looking for that aortic valve area to not change as you increase that flow, just the mean gradient should increase. And you're also measuring the contractile reserve, which is defined as greater than 20% increase in the stroke volume. That's important. If there's no contractile reserve, and even if it is severe aortic stenosis, that predicts high operative mortality for surgical or surgical aortic valve replacement. So that may be somebody that instead you would choose TAVR. So this is looking at calculating the low flow, low gradient aortic stenosis. And again, they're just going through the continuity equation in this particular patient. We're measuring the left ventricular outflow tract here, it's 2. And you can see this is what it looks like. So in this protocol, you're going to start off at 5 mics of dopamine, and you're not going to go more than 20, just because, you know, you can get VT, you can get hypotension with dopamine, you can get all these things that can lead to the death spiral in aortic stenosis. And believe me, I've seen it in the echo lab, but you don't want to go more than 20, okay? And basically, what you do is more than 20, you don't have to go to 20. If that peak velocity is 4 or greater, you're done, right? So you're also looking at the peak velocity. So in this particular case, we didn't go to 20, we just went to 10. And you can see at, this is just giving you the pulse wave at 0, 5, 10, and in 1 minute into recovery because we stopped at 10. And you can see that the time velocity integral is increasing. That's telling you the stroke volume is increasing, the flow across that valve is increasing. When we look at the continuous wave Doppler that corresponds with that, you can see that we started off with a mean gradient of 25.6 and the aortic valve of 0.6. At 5, we're up to 28.3. The valve area is still 0.6. And at 10, we're up to 42.1. The peak velocity is 434, so the test was stopped appropriately, right where it needed to be stopped. And our valve area is still 0.6. So this is somebody who has severe low flow, low gradient aortic stenosis. This is classic textbook example. So now we're going to switch to mitral stenosis. Mitral stenosis, like aortic stenosis, is an integration of findings. Again, you have patients with you need a patient with classic symptoms. Usually the murmur is much harder to hear in these patients. The echo will allow you to look at the mitral valve apparatus, determine the LA size, also determine RV function. It'll allow you to determine the gradient with respect to the heart rate, mitral valve area, and the PA pressure. So this is the most common form of mitral stenosis worldwide. This, of course, is rheumatic mitral stenosis. And you can see because the commissure fuses, you get this hockey stick deformation of that anterior mitral leaflet. When you look at it in the short axis in the upper right-hand panel, again, the commissures are fused, so it opens like a fish mouth. And because of that gradient across that valve, the left atrium enlarges, but the ventricle is spared. So you can see the left ventricle is normal function, no thickness, looks absolutely normal. Now, the most common mitral stenosis in the United States is calcific or degenerative mitral stenosis. And what happens here is you get calcification of that posterior lateral mitral annulus. It then encases the posterior leaflet, so the posterior leaflet becomes fixed. And you can see that clearly in the upper right-hand panel. But because the anterior leaflet, provides most of that area for the mitral valve, you can see it's relatively spared in this disease. So the severity of the stenosis is usually not much more than mild, which you can see in that bottom right-hand panel. Now, if we look at mitral stenosis severity according to the guidelines, it's listed here, much simpler. It looks, because there are only 3 things, but not really. And again, the caveat for all these measurements of severity is this is at heart rates between 60 and 80 and in sinus rhythm, because when you're not between 60 and 80 or in sinus rhythm, then there's problems with almost all of these measurements. So how do you determine the mean gradient across that stenotic mitral valve? Again, it's using that modified Bernoulli equation. So you measure all those velocities under that stenotic CW jet, divided by the number of measurements made, and multiply by 4. Now, there are pitfalls only measuring the gradient, just like there are in aortic stenosis. So if you have high flow rates, it's going to lead to high transmitral pressure gradients with only a moderate degree of valve narrowing, and this occurs with tachycardias, mitral regurgitation, and anemia. If you have low flow rates, you're going to have low transmitral pressure gradients despite severe mitral stenosis. Again, this is your cardiomyopathies and profound bradycardia, and AFib, again, because of its beat-to-beat variability, has problems. So this is looking at calculating that mean, calculating that mean gradient in a patient example, and you can see here that the mean gradient is 5, which per the guidelines is mild mitral stenosis. When we calculate it using the pressure half-time, the area, which is 220 minus that pressure half-time decay, you can see that the valve area is 1.2 centimeters squared, which is consistent with moderate mitral stenosis. So when you have this, because this doesn't happen infrequently in the echo lab, you have to look at the case really, really carefully and try and figure out which one's correct. So for this, I'm going to speed it along. In this particular case, if you look at the heart rate here, the heart rate's only 49 beats per minute. So that's outside that 60 to 80 range. What that does is it prolongs the diastolic filling period and allows that pressure to decay significantly, so that mean gradient decays significantly. So it really is going to cause you to underestimate the severity of mitral stenosis. The pressure decay, though, the rate of decay is the same. It's just the absolute gradient decreases. So the pressure half-time here is more accurately assessing the severity of mitral stenosis. And this is just a diagram showing you that in pictorial form. So if you have an average heart rate, that mean gradient is going to be could be around 9, because you take all those 4V squareds and you can see some are tall, some are short, and it's going to mean out to 9. If the diastolic filling period is very, very short, then they're all tall, so the mean gradient is going to be much, much higher. If that diastolic filling period is very, very long, then you have more short than you have tall, so your mean gradient is going to be much, much lower. So this is looking at planimetry. You can planimeter that valve to try and get a mitral valve area. The only problem is it has probably more pitfalls than anything else. Frequently, the image is just not good enough even to start. If you have a deformed valve anatomy, it's hard to trace. If the gain settings are too high, there's so much blooming artifact from the calcium on the valve that you're going to underestimate the mitral valve area. And if you're in the wrong tomographic plane, you're going to either over or underestimate depending on exactly where you are, because you need to record that smallest area at the leaflet tips. So how do we calculate the mitral valve area? We talked about the pressure half-time, which is just 220 divided by the time it takes that pressure across that valve to decay in half. And this is just looking at the original data, comparing how accurate that is, non-invasively to invasively determined measurements. And you can see that the correlations was very, very similar. Now, there are limitations for the pressure half-time for mitral stenosis. One is atrial fibrillation, because that diastolic filling period, again, is varying with that RR interval, so there's a lot of beat-to-beat variability. Aortic regurgitation, there's a problem because it increases your left ventricular and diastolic pressure, so this is going to affect your pressure decay. If you have changing LV and LA compliance that happens in mitral stenosis, again, you're going to have a problem. And also, if you have a nonlinear early diastolic velocity slope, if that pressure half-time decay is constantly changing, again, it's not going to accurately assess your mitral valve area. So this slide real quickly is just showing you all patients and patients in normal sinus rhythm, looking at non-invasive versus invasive determining pressure half-time. And you can see that the correlation is much nicer if you exclude all of those patients who are in atrial fibrillation. I'm going to skip through this because we got to get to Dr. NABI's presentation. So this is just looking at the different mitral velocity profiles and pressure half-time contours. So in order to use the pressure half-time and for it to be accurate in assessing your mitral valve area, there has to be one predominant slope. So there has to be one slope that occurs more than 50% of the time. So in the first example, you could use that, and it's showing you where that slope would be. In the last two examples, the slope is constantly changing, so you couldn't use those contours to determine your mitral valve area. So this is an example of a patient. So this patient has, you can see the mitral valve's really thickened, and you can see the hockey stick deformation. You can see there's also a lot of LVH, and that's probably because of the concomitant aortic valve disease, because this patient has a prosthesis in the aortic position. You can see that we went ahead and calculated the mitral valve area using the pressure half-time, and it came to be 2.8 centimeters squared, which is insignificant mitral stenosis. When we use the continuity equation, and this time we use calculate the stroke volume through the right ventricular outflow tract because of that aortic prosthesis, we got the valve area to be 1.45 centimeters squared, which is consistent with moderate MS. So again, now you have to go back and you have to say, well, which one is it? So in this particular case, you can see that you shouldn't use the pressure half-time, right? Because there is no predominant slope. It's constantly changing, just like one of those examples that we saw in the cartoon on the previous slide. So when you see something like that, the pressure half-time is not going to be accurate, and you have to rely on some other measurement of valve severity. The continuity equation in mitral valve stenosis, same as aortic stenosis. You need the stroke volume, and then you divide it by that CW time velocity integral across that stenotic jet. There are limitations for mitral stenosis, as in the continuity equation for mitral stenosis. It includes AFib, aortic regurgitation, mitral regurgitation. Aortic regurgitation, the problem just is that you cannot use the stroke volume through the left ventricular outflow tract. And why? Because there's just extra volume there, so it's going to inflate your time velocity integral. If you use that as the stroke volume, it's going to allow you're going to underestimate the severity of mitral stenosis. So if you use the stroke volume through the right ventricular outflow tract, you'll be okay as long as there's not significant PI. So this is another example, and basically, again, we're calculating the pressure half-time. It's telling us it's 1.2 centimeters squared, moderate MS. When we went to use the continuity equation, it came out to be 0.89 centimeters squared, which is severe MS. And again, this is where you go back and you look at the clips all over again and you try and figure out what's going on and which one it is. So in this particular case, I didn't show you a color picture, but it would have been helpful. You can see that there's significant mitral regurgitation on those continuous wave frames in the upper hand panels. So there's significant mitral regurgitation here. What the mitral regurgitation does is that's extra volume, so it's going to inflate your continuous wave. It's going to inflate that time velocity integral, that continuous wave signal across your stenotic jet. It's going to inflate that because there's flow there from the regurgitation going back and forth, back and forth. If that number becomes larger, then it's going to cause you to overestimate the severity of mitral stenosis because that's in the denominator. So if you have significant mitral regurgitation, you just can't use the continuity equation. You got to rely on something else. So like with aortic stenosis, mitral stenosis, you have to integrate the findings. So you have to integrate the patient's symptoms with the gradient, with the mitral valve area. And if they don't all fit, like let's say that the gradient is 5, the mitral valve area is 1.5, but the patient's having tons of symptoms. And who does that happen to? Well, the obese patient. So you're trying to figure out, is this valve area too small for this very obese patient, or are they just symptomatic because they're very obese? So in that particular case, an exercise Doppler will help you determine whether or not that valve is physiologically too small for that person. And we combine that with bicycle stress echo. So you start off at 25, 50, 75 watts. And at each stage, you measure that mean gradient across that valve using continuous wave Doppler and the PA pressures. That's all that we want, just those two things, right? And then basically what you're looking at is if that mean gradient is more than 15 at peak stress, or that PA systolic pressure is more than 60, that valve is likely physiologically too small for that patient and causing their symptoms. What's the role for TEE in mitral stenosis? Well, only to evaluate mitral regurgitation, somebody who's having a whole lot of symptoms, mean gradient may be higher than what you'd expect for their mitral stenosis. Their PA pressures also may be higher than what you'd expect for their mitral stenosis. These valves are very calcified, so sometimes and the jet's very eccentric, so sometimes it hides on the transthoracic. So you're using the TEE to see if it's actually much worse and was hiding on that transthoracic exam. And of course, for pre-balloon valvuloplasty, you use it also to grade that severity of mitral regurgitation. There really is no role for catheterization in mitral stenosis unless the echo is uninterpretable. And finally, this is the splittability index, or the Wilkins score, and it helps you determine the suitability for mitral valve balloon valvuloplasty. You can see all the different categories. It's looking at the mobility of the valve, the subvalvular apparatus, thickening of the valve, and calcification of the valve. In each category, you get a score. If that total score is less than 8, it's suitable. If it's 8 to 10, it's maybe suitable, as long as that calcium is distributed uniformly through that valve. If it's more than 10, it's absolutely unsuitable for valvuloplasty. So this is just giving you some examples. The first one is about a total score of 5. Most of that score is coming from the valve being thick, but it's very mobile. And the subvalvular apparatus, you can see, is the chordae are very shortened and calcified there. The one in the upper right-hand panel, now about an 8. Why? Because it's less mobile. There's more calcium, about the same thickness, and the chordae also are calcified. But that one does look like it's still suitable for valvuloplasty. The one on the bottom left, again, you can see that's about 11. And again, why? Because it's even more calcified, even more thickened, even more immobile. Just the tips are moving. So that one would be unsuitable. And the very last one has a total score of 15 because it's even thicker, even more calcified, even more immobile. So again, the score is best determined using, usually it's best determined using transthoracic and not TEE, but TEE can help you to look at the valve apparatus a little bit. So that's it. I'm going to turn it over to Dr. NABI.
Oh, sorry. For the fellows, if you have combined regurgitant and stenosis lesion, where the regurgitation is more than just a little bit, we don't care about severe AS with a bit of AI. But you have AS-AR, where the AR is now at least, let's say, 30% regurgitant volume. Valve area is worthless, because the valve area is always going to be mild to moderate. In that situation, that the patient is feeling is the pressure overload of the gradient and the volume overload. So when you have combined MSMR, combined AS-AR, where the regurgitant component is important, then the valve area is an academic exercise. You really are looking at gradients and volumes, because that's what a patient is feeling. And that's why people with those combined lesions frequently become more symptomatic faster, because they're getting beaten on a pressure load, and they're also getting beaten on a volume load.
Good afternoon. I will be discussing the valvular assessment by CMR portion of it. So I think before just we get started, it's kind of important to know what kind of CMR has all these different sequences. So what kind of sequences are the real strength when it comes to assessing valvular heart disease? And those are some of the terms you may have heard: the SSFP, or the steady state free precession SINI sequences. This helps us to determine a little bit about valve anatomy and motion. We can calculate ventricular volumes, and from that calculate ejection fractions. And then the other big sequence that we use in valve assessment is the phase contrast sequences. And these are sequences really that mimic your echo Doppler. And as we get in the next few slides, I'll show you the similarities. Okay, so this is our classic SSFP sequences that y'all have been used to seeing now. In general, we create a stack of short axis SINIs starting from the base all the way to the apex, about 1 centimeter distance from each slice. And I hope you can appreciate, and then along with those you have our standard long axis images. And I hope you can appreciate the images have a very good high signal intensity and a very good spatial resolution. And our spatial resolution, at least in plane, is between 1.5 to 2 millimeters, whereas the slice thickness, the through plane spatial resolution, is a little bit lower, around 5 to 6 millimeters. Temporal resolution for these sequences in general is between 30 to 40 milliseconds. That'll become important in a few slides coming up. And each of these images is produced over one breath hold. And generally that breath hold is at about 5 to 6 seconds. The next important aspect is, of course, those phase contrast images that we were discussing. And so how can I describe phase contrast to you? This is really our, again, echo Doppler. And the idea here is by creating changes in the magnetic field using the magnets, you can actually create a phase difference of the red blood cells that are going through that particular magnetic field. And so these protons, they achieve a phase shift based on their velocity as they're going through the magnetic field. And that they achieve a phase shift in proportion to their velocity. So with that, you can actually then display this as differences in signal intensity. And so this is an example of our phase contrast maps. There's usually two types of images. You have a magnitude image on the left, which kind of gives you the anatomy, and then you have your phase contrast image. The phase contrast images can be acquired either in plane, where you're assessing flow of blood coming at you, or through plane, or in plane, where you create a long axis slice and you can actually see the flow of blood in two different directions. And then the other aspect that's important to know about the phase contrast maps is that instead of the red and blue that you see with echo Doppler, here we usually have a scale of gray. It's usually either white or it's black, and then depending on the velocities, gray in between. And in general, you actually encode the direction of flow that you want. So if direction is encoded if you've created a field with, let's say, flow encoded head to foot, then any flow to the head would be white and any flow to the foot would be black. So that's kind of how we go about looking at these images. The other big difference is that unlike Doppler, you actually also have to select the velocity that you want to be able to visualize. So this is something called a VENC, or a velocity encoding, and you actually assign the maximum velocity that you want to resolve. And this will become more apparent in the next future slides, but just kind of wanted to explain you some basic concepts. So how can CMR help for valvular stenosis? Well, similar to echo, we hope to be able to do a couple of things. And number one is, of course, be able to calculate an anatomic valve area. Hope to give you accurate peak antegrade velocities. We can also look at ventricular function very well. And maybe now something more unique, we also have the opportunity for tissue characteristics of the muscle, being able to look at a more, microscopic level, whether there's been any damage to the heart and how that may relate to the patient's prognosis. So how do we go about measuring the valve area with CMR? Well, this slide I hope shows you what we do is we create a series. We create a series of very thin, high-resolution cine images, starting around at the level of the aortic, let's say the LVOT, and gradually creating a series of cuts throughout the aortic root. And you'd get a series of short axis slices that you see at the bottom. And the idea is to find the smallest systolic opening at the leaflet tips. So you can see why it's important for us to create several different images, because the patient may be breathing, or hopefully they're holding their breath, but there is a certain slice thickness to the actual slice that we're acquiring. So it's very important to create a whole stack of these images for us to really be able to identify that cine image where you truly are at the leaflet tips. And once you've identified that sequence, the image where you are at the leaflet tips, then you trace the maximal systolic opening. And this is what we call your planimetered or anatomic aortic valve area. Now, if in small series of patients, this has been compared to planimetry by transesophageal echocardiogram. And I hope you can see on the left-hand side of the screen, using our particular sequence, the SSFP, that it does reasonably well in conjunction, in similarity to another technique of planimetry with TEE. Another very important point with planimetry is that, believe it or not, the actual planimetered measurements are actually slightly larger than the valve areas the physiological valve areas that you achieve with the continuity equation. And this is just a good graph on the left-hand side of the screen showing that for each of the transthoracic echo measurements, by the physiological measurements, your aortic valve measurements planimetered are slightly larger. And so one of the things that we try to do here in our lab, so in order to avoid any confusions between the two services, is knowing this relationship. We actually, when we trace amongst ourselves, we have been very careful to under-trace just slightly. And we've noticed that gives you a much more reasonable correlation with what you're...
So that's the Methodist fudge factor.
That's the Methodist fudge factor, yes.
But also remember that anatomically, with TE or CMR, you're looking at maximal opening of a valve.
Yes.
Where the equation we use, continuity equation, is really a mean valve area because you're doing stroke volume, mean TBI. So you're really looking at sort of more of a mean valve area. So it makes sense that a structural valve area, being maximal, should be a little bit bigger than a functional valve area.
Yeah, that
makes all the sense in the world.
makes sense.
Yeah.
And that's one of the things that we felt that in order to avoid any confusion, when we have these referrals, just to be a little bit more conservative in the way we trace, and then we get very nice correlations.
I personally wouldn't do it. I mean, I would measure whatever you have. I mean, knowing that anatomic area is always larger than functional effective orifice area. That's why it's called effective orifice area, because that effective orifice area may be different at higher flow rate compared to low flow rate. There are many things that go into it, and your fudge factor may be different than somebody else's fudge factor. I don't know how much inward you want to draw it. Just draw it and educate people that this is a situation, there's a certain relation. And you can state it in your conclusion. This is anatomic area compared to an effective area, so at least.
Yeah.
But you understand my point is you got to measure what you can measure.
Yeah. And which we do. We always put, anatomic valve area. But yes, that's one take-home point everybody should know, that the valve area you're getting may well be larger than what you're seeing back home.
It's about almost 0.2. Almost 0.2, right? On the average, some of them less, but on the average,
on the blend outlet.
Almost 0.2 larger. So you could put in your, as I said, this is anatomic area, and on the average is about 0.2 centimeters squared larger than an effective orifice area. So people know what you're looking at, as opposed to trying to change an anatomic area to even the Gorlin equation has factors, right, for mitral, et cetera, to change from an anatomic, which was validated on 11 patients, not validated either.
Cadaver.
Go and take a look at it. It was not the biggest science. That's what you do now. I mean, this is a very important slide.
Is this the same for CT too?
Yes, absolutely, same for the CT. The skill is to be able to be at the leaflet tips and then make sure you identify your maximal systolic opening.
And this
So
also
that's-
throws into question not the methodology of your TE anatomic area relation to effective orifice area, because all of these are anatomy, right? And the resolution by TE at times you have a blooming artifact of the high calcium, right, that makes the orifice a little smaller. So, I mean, each technology has its own issues in different ways.
Sure.
And remember, it's one of the characteristics of this aortic stenosis that you put in addition to everything else that you know about.
Absolutely. So the other thing, of course, we can acquire is the peak velocity. And this is where it becomes important, where I was describing to y'all. So how is this done? Well, we create, again, once you've identified that slice where you believe is at the leaflet tips, you create a through plane phase contrast. Through plane meaning the blood is flowing through the slice. And this is a little bit different from echo Doppler. In echo Doppler, you want the beam to be parallel to the flow of blood. With CMR and phase contrast CMR, we want to be perpendicular to the flow of blood. So what you do is, in order for it to resolve the velocity, we have to actually assign the velocity where of what it detects. So what we do, and what happens is, if the velocity that's going through that valve is higher than the velocity that we are is higher than the velocity that we've coded with our venc, you will see aliasing. What is aliasing? You'll see snowing of the picture. You'll see both black and white in the same picture image. So if we look at this sequence up ahead, what you'll notice so you have the magnitude image in A, which shows you we're at the leaflet tips, and then you can see velocity was coded at 375 centimeters per second in B. But if you look at the image, you're seeing both white and black, and that's what we call aliasing. So that tells us that the velocity that we set was still too low for the velocity that was traveling through this slice. Hence, the very next slice, you go up to 400, you still see aliasing. Finally, it was set at 425, and I think we'd all agree, now you're seeing this white laminar flow. So here, the velocity would be reported out that the peak velocity in this case was 425, the velocity where there is no aliasing. So
in reality, is the velocity 425, or is it between 400 and
it's between 400 and 425. This is our...
Would it make more sense to actually say that in a range of, rather than put a number that probably could be true, but maybe not?
Yes.
Maybe it's 415, 410?
Yes. This is, Dr. Q, our fudge factors number 2. We report out...
The truth is coming out.
We report out the higher velocity, and the reason is...
Can you start in your report as many fudge factors?
Dr. Shah is going to be very upset when he reviews this on the video. No, and there's reasons why we choose the higher velocity. And that's because we know the velocities will be slightly underestimated by phase contrast CMR. And because of the methodology. Why? Number one, we have, in spectral Doppler's temporal resolution is 2 to 3 milliseconds. Our temporal resolution is 40 to 50 milliseconds. So right away, you're not going to resolve the peak velocity. Second thing is, we have a slice thickness that we're using. So, in that particular slice, over 50 milliseconds, you're getting kind of an average velocity. And then, of course, you want to make sure you're truly perpendicular to flow. And we know sometimes the aortic stenosis jets can be quite eccentric, to say the least. So knowing that in general, we may also, because of our lower temporal resolution, also because we have some volume averaging, because of our slice thickness, we know our true velocity is slightly lower, and therefore we choose the higher velocity. If you do that, here is one study, again small, looking at the relationship between peak velocities between transthoracic echo and CMR, and you can see what's reported in the literature that the relationship is not bad. It's pretty good. This has, of course, this aortic stenosis assessment by CMR has been studied extensively in the literature, comparing it both to transthoracic echocardiography and transesophageal echocardiography. And in general, I didn't get a chance, won't go into all the details of the studies, but in general, again, the R's tended to be in the 0.8 to 0.9 range. Now, one of the things that's always come up is, can you actually calculate a physiological valve area? And we had Dimitri, who also worked on this extensively, and next year I'll have his slides also as part of the presentation. But yes, it is possible for us to calculate a physiological valve area along with our anatomical valve area. Why? Well, because as in the continuity equation, I can identify the LVOT. Once I've identified it, I have an area. We know we're very good at looking at flows through that area, which is then your TVI. And then if I look at the velocity curve, flow curve going through the aortic valve, similarly we can calculate, using the continuity equation, we can calculate a valve area. And this again was looked at in the literature in this particular study. And again, you can see physiological valve area by CMR, where it came very close again to that of echocardiography. So it is possible. Now,
You tend to get a smaller number than the structural?
Yeah, Dr. Q, we haven't been,
Doing it?
we don't routinely do it here in our lab, only because of the way we've been, performing our measurements. Now, of course, with CMR, you have the opportunity to look at the heart structurally as well. So one of the things we can definitely do very easily is look at the type of remodeling. Everyone is very well familiar with the different types of remodeling that can occur in aortic stenosis. But it is important to note that some patients do not thicken. They may actually dilate, and the walls may actually be thin. So that's one important thing to know. And in this study, they looked at the relationship between pattern of LV remodeling by the LV mass index and the aortic valve area, showing that there was still a lot of heterogeneity, explaining, and this may potentially explain why patients, why one patient with a valve area of 0.8 has tremendous symptoms, whereas another patient with a valve area of 0.8 has no symptoms. Just the fact that how the heart has remodeled. And we know there's a lot of factors that go into why a heart may, factors that may go into why a heart may maladaptively remodel, such as hypertension or just basic genetics. Some people, whatever pressure overload, they tend to, fibrose more or thicken more.
This been looked at? Because this could be a great project for fellow.
This was
integrating hypertension, aortic stenosis, the LV mass, also myocardial findings of fibrosis. I mean,
this was
I don't know who else have done this and what publication, but this could be a very nice project.
This particular,
we have so much AS around here.
Absolutely. This was a small study, 91 patients. That's really, that's what I've seen out there.
Any hungry fellow there looking for projects, this could be a very attractive project.
One of the things, of course, with CMR you can also track, LV regression, mass regression. This is just a case of patients who were pre and post AVR, and you can see mass nicely come down, so we can very accurately quantitate mass. The other big thing is fibrosis, and we know CMR is a great technique for looking at fibrosis, whether it's interstitial or whether it's replacement fibrosis. And so we know from surgical studies in patients who have gone to the OR, had valves taken out, and had a biopsy of the muscle, that the more fibrosis that you have, the worse your survival post-AVR. And one of the techniques, of course, we have is late gadolinium enhancement. This is a technique which you all are very comfortable with here. White is dead. And basically there's normal on the top left there. You have a typical CAD pattern that you're seeing in the second top image. The one that we're concerned with aortic stenosis is what we call this mid-wall fibrosis, where it's this patchy infiltrate in the middle of the ventricle. And studies have shown that if you take patients with aortic stenosis and perform an LGE on them and then follow them through time, that of course those patients who have no LGE, these were moderate severe aortic stenosis, they tend to fare very well in the long run. There was no adverse cardiac death. The survival was preserved. Whereas those patients who had this mid-wall fibrosis had prognosis that was as bad as patient who had demonstrable CAD scar. So very, very important finding that this mid-wall fibrosis is not benign. It tells you that there has some damage or structural abnormality that is taking place in the heart that has real consequences for this patient. So, and in this particular study, it was a 6-fold increase in mortality. And when you looked at the multivariate analysis for all-cause mortality, it was actually mid-wall LGE that had the highest hazard ratio, even higher than ejection fraction, which we know is not necessarily the best measurement of systolic function, more than the infarct LGE or whether the patient went on to have AVR or not.
It's a bit strange, huh? It's strange, I would say, because an infarct LGE means that you have coronary disease on top of aortic valve disease, right?
Yes.
And yet, unless you tell me the mid-wall LGE is so much larger and the ventricle is so depressed or is arrhythmogenic, I mean, what's the etiology of the mortality?
Yeah.
Sample size.
Sample
size was small.
Yeah.
I mean, you see my point.
I see your point. Yeah, why don't the patients with, the CAD scar, they have known CAD, why aren't they doing worse? These are small studies again. I think, we can definitely, 143 patients. I think definitely you're right. With the number of cases we've done here, I think Alpana is working on this. Alpana is going to give us an update next year.
Yes. We have like over 1,000 patients.
All right.
For AS, I think like close to 2,000.
Like it.
So I'll show you just a few cases to show you the CMR and echo in action and how we can use it. This was a 67-year-old mechanical MVR referred for hemolytic anemia and physical exam and echo findings consistent with severe AS. Physical exam findings consistent with severe AS. So he had aortic stenosis Doppler here, and you can see that the peak velocity was 3.2. Echo images, you couldn't tell if there was any PVL because, of course, you have some artifact from the valves. Question was, could there were, here the discrepancy between physical exam and echo findings. They proceeded to a CMR to help determine the severity of the aortic stenosis.
The valve looks really bad.
The aortic valve? Yeah, aortic valve's not
looks
open.
worse than the Doppler, which is not uncommon, but still.
Right.
And the LVH is pretty impressive. So.
And in this particular case, it'll be just as, you really, like as KARLA has said, you really have to hunt for multiple different sites the peak jet. And you really have to be parallel to that flow of blood. So here's the CMR images, the same patient. You can see again the aortic valve. You can see flow acceleration at the valve level, very important. In a few slides I'll show you why. You can see that the valve does not open, as Dr. Q astutely pointed out, the ventricular remodeling with LVH, and then you can see the mechanical valve here. And as well, if you look at these sequences, I really can't identify any significant mitral regurgitation, at least by these images. We performed, as what we've discussed, planimetry of the aortic valve. A series of high-resolution cines were performed through the aortic root. We identified that slice sequence, which appeared to be at the aortic valve leaflets. The smallest systolic opening, smallest maximal systolic opening was traced. And we planimetered a valve area of 0.9 centimeters squared. So truly, by our definition, severe aortic stenosis. We always hope for a good correlation with our phase velocity maps. And here you can see that at 3 meters per second, we had aliasing, where you see both the black and white flow, just indicating that your flow is higher than the velocity of 3, and therefore, the computer codes it in the other direction. At 3.5, you had aliasing. At 4, you had now just a pixel of a black dot. I know it's hard to see, but right there, there's a little black dot. At 4.25, it became a little bit more prominent, and by 4.5, it completely went away. So here, using the logic that, where do you not have aliasing? By 4.5 meters per second, we did not have aliasing, and so that was determined to be the peak instantaneous velocity through that aortic valve. So here we have congruence between our planimetered and our peak velocity. So we were very confident in calling this severe AS. What was nice was we had a 3-chamber view, phase contrast, and here for the first time we could clearly make out that there was a paravalvular defect that could explain the patient's hemolysis. And this patient went on then to have calculation of his mitral regurgitation, which we've talked about in how to do in other in another course. Sure.
The left lower plane, the left lower view. No, I mean the
Echo?
the left.
Oh, it's the CMR.
The CMR. No. I mean, what I see as a jet, is that a jet of mitral regurgitation and different?
Okay, yes.
black jet?
Sure.
Or is this a?
Yes.
Do you see my point?
Yes, I do. I'm seeing if I can bring. Okay, here we go. So there is this kind of puffiness here. Those could be closing jets. Those could be some artifact from the metal there. There was a suspicion here.
You see my point? There's a puff of black.
Yes,
that comes out
posteriorly.
Yes.
Yeah, and that is exactly what you're seing on the phase contrast CMR. So it was there for the sake of some excitement in the talk. But you can see now the very nice correlation. So that puff your eye clued in on was accurate by the phase contrast in plain CMR. Okay, another very useful place for where to consider CMR for AS assessment.
It's important for us to think about it, okay? This ventricle is contracting very well, right? By Doppler, your peak jet is 3.2 meters per second. But you have to think in this individual who has concomitant mitral regurgitation, that flow in the LV outflow tract may be lower than what it is, and therefore, your peak gradient is on the lower end.
Right.
So you didn't give me valve area, you gave me a gradient.
Right.
So you have to think about these because you start thinking about valve area when the gradient is not in the extremes. This is when you always think about valve area. These are actually the current ACCHA recommendations. If my gradient is 40 and above, I don't care, it's bad. Even if it is combined SAI, it's bad. If it is very low, below 2.5, I'm not worried. If it is somewhere in between, I need to figure it out and understand why is the gradient so much, particularly when you see a discrepancy between a bad aortic valve looking structurally and the gradient that's not so bad. So I have to look at flow because most likely in that first one when somebody has hemolysis and so many other things, your first thing is there's some very valvular leak.
And Dr. Q, Dr. Z, you probably agree that your valve area, even in that setting, will likely be underestimated. And probably the DVI is probably the best way to go about it, I would say.
It's lower flow, so I have a lower gradient, but my valve area is still better.
Agree, yeah, absolutely. Another very helpful case of where AS assessment by CMR is very helpful is those who have bicuspid aortic valves. We can do the usual stuff, but where we are very helpful with is assessment of the aorta, looking for associated aortopathies, looking for coarctations, and looking for, of course, aortic dissections. And so a very valuable technique where you're able to image the entire thoracic aorta. Obviously, if these patients are going to go on for surgery, you want to identify these abnormalities prior to surgery. So here's just a few more examples of cases that I wanted to show to y'all. Here, if you take a look at the SSFP images, you can see that there is flow acceleration, but if you really pay close attention to that flow acceleration, you'll notice it's not occurring necessarily at the valve level. It seems to be occurring in the LVOT. This was a fantastic case of subvalvular aortic stenosis or due to a membrane. And here, we can obviously maybe sometimes these membranes can be very thin, very difficult to see, so it may not be easy for us to have an area of the LVOT, but we can resolve velocities in the LVOT if we had to. But the strength is we can also planimeter the aortic valve and show that the aortic valve is normal. And this is just an example of that. Here you had both SAM as well as a very calcified aortic valve that was not moving. You know by CW you're going to have accumulation of velocities. With CMR, I could planimeter the aortic valve and to determine the valve area and separately resolve both the velocity in the LVOT and at the aortic valve level. Pulmonic stenosis is very similar to aortic stenosis. I know we're getting short of, we're over time, so I will, we do it the same way. Mitral stenosis is also we are able to do. Here you again want to make sure you are truly at the leaflet tips. You want to create several short axis slices at that of the mitral valve leaflets, truly identify the smallest systolic opening at the leaflet tips, and you're able to planimeter this. This has been shown in comparison to transthoracic echo, both by velocities, peak velocities, pressure half time, to be reasonable in comparison. And this is just a case of mitral stenosis here. You can see the hockey sticking of the valve. Notice we don't see calcium. Calcium is not proton, so we have, Wilkins score for us is very difficult to do. But here I can, again, identify at the leaflet tips, create a slice sequence where I can planimeter the valve and also calculate a velocity. You can see the secondary effects of that with the markedly enlarged left atrium. Here's another example in a patient with both MS and AS. But what was very unique to CMR, I think, is that we can readily identify thrombus in these patients who often have very large atria and concomitant atrial fibrillation. So what are my summaries for CMR? Please do consider it, whenever you have poor acoustic windows with echo, whenever there's a discrepancy between your comprehensive 2D echo and Doppler examination and your physical exam, whenever there's a question what the true severity of the lesion is, you have another technique that can get you in the right ballpark. If there's ever an issue of assessment of viability or tissue characteristics, or whenever you also need to know information about the aorta.
Thank you.
Thank you.